Welcome, Doug, to our Zoom recording here in the Firefly headquarters in Sligo on the west coast of Ireland. And it's so nice to see you all the way from, I imagine, sunny California, Seal Beach.
It is a sunny morning in Southern California on the west coast of the United States, yes.
Well, I'd like to firstly introduce my colleague, Sarah O'Connell, who's sitting to my right here. And Sarah is a podiatrist. She set up her own clinical business in Galway, but she also does some work in our private practice in Sligo and does some MSK training and educational workshops for us within Firefly the Lab. And she has a particular interest in complex hindfoot and ankle conditions, and she's interested to be a part of this presentation. So she's got some nice questions to ask you along the way. I think what I wanted to start with is for all the podiatrists in the UK that are listening in, is to also mention your new book that has just been published on the pathomechanics of common foot disorders. There it is. So everybody have a little look at that. And this is a must purchase book in terms of how we in the podiatric profession treat common foot disorders. So I think, well, I've ordered one, Doug, so it's en route to me, but I have started to read the digital version. So thank you for sharing that with me.
My pleasure.
The next time you visit Ireland and we're enjoying a nice glass of red wine, I'll get you to sign it as well. So over the years, Doug, I want to just start a little bit about the history of the Richie Brace for me and how it's relevant to some of the podiatrists who are only starting to use it or who haven't used it. And I think the story and the narrative is quite interesting in that, you know, probably 15 years ago, I was visiting North America, going to PAFOLA conferences and trying to bring back nuggets of information or new technology or some type of evidence-based treatment to my colleagues here in Ireland and in the UK through Firefly Orthoses Limited. And I kept coming across Richie Braces on every exhibition stand that I visited at the PAFOLA conferences. And initially I was somewhat hesitant to move in the direction of AFO therapy because at an undergraduate level here in the UK and Ireland, we were never taught how to use AFOs. And our training was very much focused on functional foot orthoses and palliative type foot orthoses, so offloading strategies, but it was all about the foot. And we weren't really starting to look at, well, what was happening at the level of the malleoli, what was happening further up that kinetic chain, you know, at a detailed level. So for me, I think this is one of the most interesting products that really Firefly has had the pleasure of being able to distribute in the UK and Ireland. And we also supply it to various practitioners in Europe, but on a small scale. So what we're finding in really the UK is that still the budgets for AFOs are controlled by orthopedic medicine and predominantly orthotists. So we're still not seeing huge volumes of these products being used. And yet the significant impact they can make for a patient is just huge. So, you know, I'm really excited to share it with my profession. And what excites me is that this foot plate, I don't need to tell you, this foot plate is a custom-made, intrinsically balanced foot orthotic device that is manufactured to the medial and lateral malleoli. So it's balanced to the person's ankle joint axis. And then these uprights are mass-produced and added. But what it's done for me in clinical practice and my colleague Sarah and lots of podiatrists that are using it is it's increased our scope of practice. So we can now treat pathologies that previously we couldn't. So as an example, foot drop, that's one of the classics. But also some of the complex arthritic conditions affecting the subtalar joint, the ankle joint, you know, severe ankle instability. And some of the results have just been quite outstanding. And I know on your own website, you've got a lot of videos demonstrating, you know, before and after. And we have multiple cases right across the spectrum in terms of patients from young right through to senior citizens, but also very interestingly in elite sports people and also in the military who have returned to quite active participation in their sports and activities. So it's a product that I think, wow, we need to use more of this for the right patients. So with that in mind, okay, tell us the story of how you came about to create the Richie Brace. Tell us about that. How did it happen?
Yeah, well, that was actually a great segue into that question, because Martin, in the United States, and even today, there is no formal training in the schools of podiatric medicine about AFO therapy. And certainly in my training in the late 1970s, we had very comprehensive lectures in biomechanics taught by Merton Root himself and John Weed and Ron Valmassi and Chris Smith and other luminaries in the field. But there was no mention of AFO therapy at all. It was all foot orthotic therapy as the cure-all for all these conditions we were being taught about. And I became acquainted with, I will say, the concept of bracing because I established a sports medicine practice. And what little podiatrists dealt with devices that went above the shoe, it was sports bracing, and specifically air cast, or as we call them, air stirrup type braces for ankle instability. So early in my practice, I was dispensing prefabricated ankle braces because I was treating a lot of athletes with ankle instability and even tendinopathy conditions. We were using prefabricated ankle braces. And I immediately was challenged with the dilemma of a patient who was wearing a pair of custom foot orthoses, and I would now fit them temporarily with an ankle brace. Whether it's a lace-up brace or an air stirrup, it would not fit compatibly in the shoe with their foot orthotic. And often they would have to take the orthotic out of the shoe so they could wear the ankle brace. And so I had this in the back of my mind. It would be nice if we could combine the benefits of a foot orthosis with the support of an air stirrup type ankle brace. And that's really where the concept was, but I never executed that. I was involved in many other entrepreneurial things at the time. But in the I would say around 1993, a sales representative came in my office with what is today the prefabricated version of the Richie Brace. He was working for a company called SureStep. And he showed me this brace that looked like a Richie brace, but it had a flat foot plate as the articulated portion. And I immediately said to him, boy, it would be nice if we could make a custom foot plate for this brace. And he said, well, we don't know how to do that. And I said, well, I do. And that's when we started working together. A lot of people don't know this, but I partnered with actually 2 other companies to develop the Richie Brace. And we finally released the finished version after about 5 prototypes in 1996, quite a while ago. Martin, I think you probably saw that at PAFOLA meetings right after the new millennium, around the early 2000s is when I brought the PAFOLA labs into my distributorship, because I was friends with all those folks and they were truly the premier foot orthosis manufacturers in the United States. And they were the perfect partners for me to introduce this. So
I think
that's about the time you saw it.
I think the first time I saw it, Doug, was in Montreal in 2002.
Okay.
Which was one of the first PAFOLA conferences that I went to.
Right.
It's interesting that, with the custom foot plate, you can treat the triplanar nature of the foot. And that's what I think some people miss. Now, with the flat foot plate, yes, you might be able to treat something like a sagittal plane deformity for a foot drop, a flaccid foot drop. And there are various products out there that are of a carbon fiber or a plastic nature that have a very flat foot plate. But for me, the key thing has been the contouring of the device that allows you to control frontal, transverse, and sagittal plane.
Right.
Yeah, and of course, the only product of its kind designed by a podiatrist for the podiatric profession. So for me, I'm going to promote that big time because I believe in what we do as a profession is so valuable to the treatment of certain conditions and the rehabilitation of others. In our clinical practice now, one of our lead podiatrists uses Richie braces for a period of time to aid rehabilitation. And we actually now have a team of orthopedic surgeons that actually refer for Richie brace rehabilitation. And it's part of their management. And that's interesting as well, that we don't think of the Richie brace simply as a long-term treatment that has to be put in the shoe and it stays there forever. It can be used as part of a mobilization rehabilitation program, which is fantastic. Okay.
Well, I suppose what's difficult is that when you look at research, there is really positive research, as you know, Doug, out there when it comes to using it as part of a rehabilitation tool. But obviously, majority of the research out there is for surgery. So while there's such, it's a lot of case studies and there are small kind of studies done on it, but the studies that have been done are really, really powerful and they're getting on really, really well. So it's a great device for that.
Well, those are really good points. And, over the last 25 years, we've learned applications, just like you described, Martin, that we never envisioned when we first introduced the brace. Its ability to be an adjunct to rehabilitation was something we never thought of. But we discovered it when we started using the brace specifically for tendinopathy conditions. And we would tell practitioners, why not try the brace before doing surgery? And if the brace fails, you can use the brace as a recovery tool to enhance the rehabilitation process afterward. It's a good investment up front that may avoid the surgery. And even if it doesn't avoid the surgery, it's a powerful tool to help recover from the surgery. So you're exactly right.
Yeah, maybe what we could do is just focus on some of the common conditions that we treat with the Richie brace. And let's keep it simple so that those that are thinking of embarking on AFO therapy are willing to, take that step and to contact us to get the technical support and the help in terms of the choice of the brace and the choice of the hinge. I mean, one of the key things I think about the prescribing of these, Doug, is that fundamentally you're posting them to calcaneal vertical. And that keeps it relatively simple for the podiatrist. The key thing is that in the process of casting or scanning, as some practitioners are now doing, we want to see a correction of the forefoot supinatus. And this is key to the success and the design of the product. And it reminds me of when I took the opportunity to hop on a plane and fly to Seal Beach and visit your clinical practice. Well, for the first time, I've been a few times, but the first time I went out and saw you cast someone using plaster of Paris, and you said, okay, we're now going to correct this forefoot supinatus. And I was like, okay, right, I get it. So you do that for the Richie brace. So you're going to plantar flex that first leg, get the 5 met heads all on the same plane. We can see the longitudinal arch, the medial longitudinal arch of the patient that contours their anatomy perfectly. And then you said, well, we do the same for foot orthoses. And I was like, whoa. So you correct forefoot supinatus when you're casting even for foot orthoses? That was a game changer for me to come back into clinical practice in Ireland and to share it with my colleagues in the UK.
You only shared that with me. That's the only I've ever cast.
And it was like, okay, so rather than letting someone in a plaster room or someone in a CAD/CAM room try and guesstimate the MLA, why don't you just correct it in the cast and you have the MLA? Wow, does that produce a beautifully shaped, fitting, contoured device? Thank you for that tip, because it was a game changer, man. Really good.
Well, it's interesting, Martin, that was really, that whole experience is what I put in the book, is the twisted plate concept of the foot for optimal function. And while we have labs who say, well, we can use digital correction to reduce any supinatus, deformity, whatever, you're exactly right. It's a 3-dimensional change in the entire shape of the foot that occurs when we pronate the forefoot on the rear foot, which is the optimal position for function. I mean, all of the great anatomists have said that, going back to my favorite anatomist, who is an Irishman, by the way, McConnell. he was the first originator of the twisted plate concept, but it's been embraced, and still today it's discussed in the orthopedic literature regularly now. But it's a shape, it's a three-dimensional shape that in podiatry we have recognized early on to be the success of foot orthotic therapy. The contour of that foot plate in the optimal position of function is what the magic is of a podiatric foot orthosis compared to those made by other specialties and practitioners.
Okay, so the twisted plate theory, yeah, I like it.
It's in chapter 1. You'll
up there, Doug. Which book was that again?
That's my book.
Let's see it again. Oh, it's that book again. Okay, so just for the audience, the benefit of the book again. Okay, so let's talk about the common pathologies. What do you think is the most common pathology that a standard Richie Brace is used for?
Without question, posterior tibial tendon dysfunction, aka adult acquired flat foot. I would say in the United States, that's probably 70% of our prescriptions. And anecdotally, I'll tell you, when I introduced the Richie Brace, it was going to be a sports brace for chronic ankle instability, period. That's all I envisioned it for. And like everything, we learned almost by accident, doctors started using it on other pathologies. And early on, they told us it was working in a spectacular fashion for posterior tibial tendon dysfunction. And I actually didn't believe it. And I almost discouraged people from trying that because that wasn't what I thought it could be used for. But today, by far, that has been our #1 application. I wouldn't say it's our most predictable success tool. It is very successful there, but it wasn't until 5 years later that we even began trying it with drop foot conditions and other neuromuscular disorders using other hinges than our free motion flexion hinge. So to backtrack, posterior tibial tendon dysfunction #1. I don't know whether foot drop would be #2, but I would put it close to arthritic conditions of the foot and ankle complex. I'm amazed how many prescriptions we get and x-rays I see from practitioners who are using our brace appropriately to immobilize and literally offload arthritic ankle joints and subtalar joints. And then we get into tendinopathy disorders where I think it's underutilized. We're seeing so much tendinopathy today that we didn't see 20 years ago. And there's reasons for that, I believe. But I think practitioners need to understand the power of selectively offloading injured tendons using our brace and using the foot orthotic modifications that we know we can employ because we understand the pathophysiology of how tendons get overloaded.
And Doug, would you have a specific rehabilitation program for posterior tibialis tendon dysfunction, or is there a certain guideline that you would go by?
Yes, that's a great question. I learned early on that I wasn't getting the results with posterior tibial tendon dysfunction that I wanted until I brought 2 physios into my clinic who worked full-time with me. And the minute they started implementing their protocols, just in general, from what they were taught in school for rehabilitating tendons, my outcomes improved by 50%. And so part of my lectures and teaching on bracing posterior tib dysfunction, at least 30% is focused on rehabilitation. And we follow a protocol pretty much instituted by a woman out here in California named Cornelia Kulig, who published 4 papers on rehabilitation of specifically of posterior tibial tendon dysfunction. And we invited her to one of the PAFOLA conferences. It was actually the last one in Atlanta. And she's just truly one of my heroes in all of medicine because of her ability to apply science in a clinical way and make it meaningful. And she developed a loading device to specifically isolate the tibialis posterior. And then she really combined it with top-down approach, starting with the hip, moving to the knee, the lower leg, and then balance and proprioception. And bringing all those elements together, man, that just magnified the efficacy of the Richie Brace, no doubt.
Yeah, because I think that's kind of my focus with my kind of sports and exercise medicine background. But I'm just wondering, did you have a specific one? So I'll definitely have to look that up, because I think I've just
Yeah.
taken different physio ones. But I'd like to look up whatever you're using, anyways.
Yeah, I just finished a tutorial in Australia on adult acquired flat foot. It's about 4 hours long, believe it or not, but a good 30 to 40 minutes of it is rehabilitation. And I think I sent that to you, Martin, or I had you talk to Josh Truscott in Australia. But I'd be happy to try to make all that available to Firefly so you can share it with your own
Yeah, I haven't
clients.
seen that, Doug, so that would be good to see, definitely.
Yeah.
Yeah. Okay. So in terms of then the Richie Brace for the adult acquired flat foot, for the benefit again of the viewer, really you're posting to calcaneal vertical. You've corrected your scan of the foot or your cast of the foot, and sometimes you might apply a 2, 4, or 6 millimeter curvy skive. Again,
Yep.
attempting to create a supination moment of force, and periodically you might apply a 3 millimeter heel lift. And that would tend to be pretty much the standard prescription. And of course, then you have the standard hinge, which allows plantar flexion and dorsiflexion of the ankle. If we moved on to something like the brace with the fixed hinge, tell us how that evolved, Doug. How did you get to the point of suddenly saying, okay, let's fix this hinge, let's put 2 rivets in it and stop movement at the ankle?
Well, we know as posterior tib dysfunction progresses, by stage 4, it's characterized by arthritic changes of the major joints of the hind foot and ankle. And it made us stop and realize we're going to have to start limiting ankle joint motion and stiffen the brace more, because these joints are now gone. They're arthritic, and what little motion they have is painful. And so we began experimenting with locking the uprights to the foot plate. And it's interesting, Martin, as we put those double rivets in, initially we were disappointed because it didn't really lock them as rigid as we wanted to. We found out later that was actually a good thing, because it seemed to limit motion enough to reduce symptoms, but it didn't distort the gait pattern like a really solid, rigid AFO that comes up behind the knee. And so we did experiment with using 3 rivets, 4 rivets, thicker polypropylene. And we found that if we just simply put double rivets on that standard Richie brace, for the most part, it was successful in relieving the arthritic symptoms of stage 3 and stage 4 adult acquired flat foot. So that was when we started recommending that restricted hinge. I will tell you, when in doubt, go with the free motion standard Richie brace for adult acquired flat foot, because it works most of the time, and you can always add the extra rivet later to lock it. Mm-hmm. And in my years of clinical practice treating hundreds and hundreds of posterior tib dysfunction, the majority of my prescriptions were for the standard Richie brace, not for the restricted hinge.
Yeah, I tend to use the restricted hinge for the more advanced adult acquired flat foot, but also anything with regard to severe lateral ankle instability, or any of the OA or arthritic degenerated type conditions of the hind foot. And I agree with you, it doesn't completely limit movement, but I think what it does is it transfers load from the foot and ankle up into the upright, and in doing so offloads the painful area. That's just a theory, but that seems to be an interesting approach to it. And
yeah.
I had one patient who was a young podiatry student. She was just qualifying as a podiatrist, and she had had a tarsal coalition, and she had had a surgery where her hind foot was fused in slight varus, and she was having all sorts of peroneal tendinopathy problems, and it was impossible for us to alter the actual position of the calcaneum because it was fused in varus. And we decided to go ahead and treat her with the Richie brace and to use the fixed hinge. And within 1 week of wearing it, the symptoms disappeared from the peroneal tendinopathy, and she was pain-free, and she was able to avoid having a triple arthrodesis. And, that young podiatrist, you can imagine how she felt about that.
And she
Oh
still
yeah.
had the triple
And she still hasn't had the
arthrodesis.
triple arthrodesis. You recall the
Yeah,
lady. And at the time, I was thinking, well, we're going to put her into this brace, and we're going to post the calcaneal vertical, and we're going to put a skive on it. And I think in that case, it was a lateral skive. And I said, okay, we're not going to alter the position, the kinematics of the hind foot, but we're going to alter the kinetics. We're going to alter the load. So,
Yep.
wow. And there's a lot of examples like that, Doug.
Yep.
So again, really, the fixed hinge, it's probably a little bit trickier to use for the patient to get on and in and out of the shoe and on and off the foot, I suppose. Would you agree?
I would say it is, but in some ways it isn't. One of our challenges is getting patients to orient those limb uprights perpendicular or oriented along the long axis of their leg. And the fixed position brace automatically assures that. But we'll see patients put the brace on, in a sloppy fashion where they don't tighten the back strap and their limb uprights are now tilted forward and they're not getting the optimal leverage. So I don't know, there's really not a lot of downside to the restricted hinge. It's mostly dealing with practitioners who have this vision that it's this rigid, solid AFO, and it really isn't.
Yeah, yeah. Another thing, Sarah and I were having a little conversation just prior to this recording, and it was around the choice of the hinge in terms of, say, foot drop. So sometimes you could use a fixed hinge, and other times you would use
The tamarack. It would be our most common question, is that like a podiatrist would get someone in that has foot drop and they're going, okay, which hinge? Am I going for the fixed or am I going for the tamarack? So I was kind of, I'd always ask about maybe muscle testing or, what are their dorsiflexors or everters like? Is there a muscle testing scale or standard that you would use to choose, or is it something else that you use to make that decision?
Well, ideally, the tamarack hinge on the Richie brace, and we call that the Richie Dynamic Assist brace, is suited for a patient who has anterior muscle weakness in the lower leg only.
Okay.
Okay. So in other words, they have strong calf musculature.
Yeah.
They're able to do an independent toe raise. They have good push off. And they have pretty normal functioning perineals where they're not really undergoing a lot of frontal plane instability. Now, believe it or not, there are patients like that. I mean, the average stroke patient tends to lose anterior musculature only, not posterior. And they get a foot drop, but they have everything else is relatively stable in their lower extremity, provided they haven't had a massive stroke. The bottom line is the dynamic assist is ideal for that. But if they have some lack of push off, they are lacking some posterior strength, I think the restricted hinge is better because it gives them a little bit more recoil and rigidity. It stores a little bit of energy during mid stance and helps them push off. And then if they have a lot of frontal plane instability, a good example is Charcot-Marie tooth. While that's a foot drop condition, they have significant perineal weakness with resultant varus instability of the foot. And the one shortcoming of the tamarack hinges, not real good to control frontal plane. They're just a little too flexible. And so when we're getting into extremes of varus, and that's a great example that you gave of the patient who had a fixed varus from surgery. Definitely the restricted hinge would have been a better pick, and it was, because it is much more stable in the frontal plane. So those are the differentiating features.
Okay. So, I mean, keeping it relatively simple for those that are just starting, Doug, we're talking about the standard Richie brace. We're talking about the fixed hinge. Now we've added in the tamarack hinge. In terms of things like gauntlets and other Richie brace sort of designs, I mean, that's where it becomes a little bit more complex. So what sort of advice would you give to podiatrists who are just starting? Keep it simple. Think about acquired flat foot. Think of lateral ankle instability. Think of hind foot and ankle arthritis and maybe foot drop, and treat those conditions first and foremost and develop confidence in using the brace.
Absolutely. That's a great point, Martin. And I know you've seen this as well. As I went out and taught this technology to my fellow podiatrists, without fail, they would pick the most challenging patient in their practice who had already failed with everything, and that's who they're going to start with a Richie brace on. And inevitably, they would fail because of many other reasons, not the Richie brace fault. And it taught me to caution them, just as you just did, Martin. Don't start with your most challenging case. Start with adult acquired flat foot or drop foot. And if you want to go into drop foot, just pick a very simple, mild, flaccid hemiplegia. And then when you want to get into these post-traumatic cases and nerve injuries and partial amputations or whatever that we would see, wait until you've used the brace for a while, because you need to do baby steps. You're exactly right, Martin.
Okay, thank you for that, Doug. I mean, we have some recordings from our previous symposia that we ran in London, and also from our summit, which we ran in Sligo. And delegates can connect to those presentations and learn more. And also, we have various casting demonstrations on our own website. So again, we can assist people in learning the skills. Is there anything else that we should really focus on right now? I mean, I'm conscious we've been on for sort of, 35 minutes or so. So maybe we need to wrap it up and, summarize where we are and just try and get people to engage with us in terms of Firefly, learn the basic skills, and then start treating some of these pathologies. Is there anything else you would like to add, Doug?
Well, I think one thing that you were touching on several times during this conference we're doing here is it is a very simple orthotic modification. It is balanced to perpendicular. We don't apply forefoot posting, and we don't add a lot of trinkets to these braces. So the prescription process is actually simple. And I want to emphasize that the casting process is simple. I've always told practitioners, if you know how to cast for custom foot orthoses, you can cast for a Richie brace. There's nothing different other than adding a little bit more plaster to capture the anatomy around the malleoli. But other than that, it's the same thing you're doing successfully with your foot orthoses that can easily be adapted for a Richie brace. The second thing is, I'm going to give you a little plug here too, Martin. The fact that you first saw the Richie brace in 2002, it verifies the fact that you've been working with me and implementing Richie brace therapy in the UK, not only on your own patients, but serving as a great educational source for practitioners in the UK for almost 20 years now, believe it or not. And I know of no podiatrist who has studied the Richie brace more than you have. And just listening to you today, I marvel at how much experience you've had with it. And the bottom line is you're just a tremendous resource for these new practitioners who have never done it before. They're so lucky to have you available with all your educational tools and your clinical experience that they should just pick up the phone and talk to you. And I know that you could solve 90% of their problems right from the outset.
Wow, well, thank you very much for that. And I'm very conscious of sitting here beside one of these young podiatrists who, in 2002, was. I'm not gonna ask what age you were in 2002, but let's say just having a bit of fun running around. I would imagine as a little kid. Time moves on, Doug. Okay, I'm just trying to think then if we wrap it up here. I really want to thank you for your time. And it's interesting that you set out to create this sports product, this lateral, prevention of inversion ankle injuries, and then suddenly it's being used in adult acquired flat foot at 70% of the time. It sort of reminds me of maybe this, I don't know if this is a true story or not, but in terms of Guinness, they burnt the hobs and created Guinness. It was a wee bit of a mistake.
Yes.
So I think you very fortuitously designed a product that has helped so many patients, and it's great that we as a profession can use it and help so many people. So look, I just want to thank you for all the mentorship that you've given to me and ultimately all of us. And look forward to seeing you when this sort of pandemic craziness ends and we can all travel again and we can welcome you to Ireland and the UK, or indeed we get out to the United States. So thank you for all the mentorship.
It's been my pleasure. It's been a great experience for me to work with you, Martin, and I am long overdue to return back to Sligo. I would love to come back, and you will be the first on my list once I get cleared for travel. So we'll plan on it.
We need to have you speaking at the College of Podiatry conference. So maybe that's the next thing that's going to come up. Take care, sir. Great to see you. Say hi to Kathy, and thank you very much.
I will.
All right.
Thank you.
Yeah. Bye-bye.
Bye-bye.